Hi, this is Elliot Fishman, and welcome to Facebook Live. And today is Thursday. I'm not sure what date it is, but it's the 27th of August. And it is amazing that we now been all the COVID is more than 6 months old. Many of you have been home for 6 months. It's hard to believe. It only feels like probably 2 years, not 6 months. But I hope everyone's doing well. The weather is still hot. We hope everybody, all our friends down in Louisiana, New Orleans, particularly Shreveport, and our friends in Texas are doing okay with the back-to-back hurricane. I know there's just a tremendous amount of flooding. And the only good news was the hurricane went through faster. It was tremendous winds, I think like 160-mile-an-hour winds, just amazing. But it went through faster, and I guess that sounds bad that it's faster, but faster is better because you remember last year in Houston, the problem was it rained for like 3 or 4 weeks nonstop because the storm just kind of stood on top of Houston. Things go through, at least it does the damage with this swell of the ocean and bay, but at least it goes through, so you get it over with quickly, which is good news, but still a lot of bad news. I hope everybody is okay. And we hope also all our friends in California. I know Lydiana sent me some pictures that she's in Palo Alto. The fires aren't that far away, less than an hour away in theory, but the skies are dark. San Francisco with very high temperatures and very dark skies, and kind of because from the fires and the smoke, it's just dangerous. I mean, it's unsafe to go outside basically. So, I saw the governor of California made the point that if you want to see, if you question global warming, just come to California. On the COVID front, I think the good news is if you want to go someplace that's in the green, the only green on the chart is Vermont, which means everybody's going to Vermont, and that'll be the end of that. Maryland's off the New York naughty list. Our numbers are down, and I know a lot of places across the country the numbers are down. I think 4 states the numbers are up, but the rest of the states are going down or stable, so that's very good. And again, there's nothing you can do but stay away, masks, social distancing, and also, the vaccines, the work is going on, whether it's Pfizer, Moderna, whichever the companies, AstraZeneca. I know I read there's 300 some odd vaccines in the world that are being tested beyond the Russian vaccine. But hopefully one of these will work, and hopefully will. I saw Bill Gates said, and Bill's pretty sharp on things, and he usually isn't overly optimistic type person, so that's good. And he said that he felt that by the end of 2021, this would be something in the memory books. Now you say, oh my God, 2021 is 16 months away. But the reality is, and we've said this before, that this is not an overnight thing. Even if vaccines come out the end of the year, beginning of next year, until people get the vaccine, until you have enough people who get the vaccine, till it's the point that you're willing to not wear a mask, or willing to go on a plane, or willing to go to a hotel, willing to go to a meeting, willing to take your kids out beyond just the perimeter of your house, that's going to take time. So, but hopefully we're making progress, and there's been no bad news beyond that as well. And for those people who get admitted to the hospital, fortunately there's smaller and smaller numbers, but the medical have learned how to treat, all our docs have learned medication-wise and respiratory-wise how to treat patients, and so the number of deaths, the number of things going bad of patients is significantly less. So I think the best thing to do is not to get COVID, but if you get it, I think there's less than a 4% fatality rate now. 4% is a lot, do not get me wrong, and that's nothing to be overjoyed about, but if you consider how things were in March and April, it's pretty good in that regard. It's interesting, in the US, some people are going away. I know at Hopkins people are going away, typically renting a house and social distancing. I was speaking to some of my friends in Germany and France, and in Europe, people traditionally have gone away for a few weeks in the August timeframe, and there is no virus that's going to stop them from doing that. They go to Austria, they're not maybe taking planes, they're driving a lot, and they're going to where the air is clean, in Austria and the mountains and things like that. So other countries are handling things a little bit differently. I'd like to be in the Cayman Islands with Max and Sam, but The Cayman Islands was smart. They shut everything down. So their numbers must be very, very low. But the way you keep it low is don't let people come and go. So going back to today's topic, which is incidentalomas, and I spoke about incidentalomas last week, and I made the point that incidentalomas happen on every type of imaging study, every body type, every scan, CT, ultrasound, MR, and we were speaking about CT, and I spoke about three of the bigger areas with incidentalomas. I spoke about the adrenal glands, which is really where the term incidentaloma really took flight, and I spoke about kidneys, and I spoke about spleen. So let me talk a little bit about liver. And with liver, again, the most common liver lesions are going to be benign lesions, cysts, hemangiomas. So it's easy when you have classic appearances. Hemangiomas, anywhere from 1 centimeter to 20 centimeters, most in the 3 centimeter range. Peripheral puddling, filling in from peripheral to central pattern. We talk about another benign lesion, focal nodular hyperplasia, vascular, hypervascular, but only as bright as the IVC and arterial phase imaging, more common in females, younger patients, and the lesion fills in over time. That's another lesion. And we make the point that other lesions like hepatic adenomas, which can be incidental, they have more of a regular enhancement pattern. Remember, many hepatic adenomas predisposed to hepatoma. We also know that when you look at liver lesions, there's a good article from the American College of Radiology, the appropriateness criteria, looking at liver lesions, making the point that you need to consider the clinical history. That in a patient with cancer, you really need to look at a liver lesion closer because perhaps it's a metastasis. And again, there is some overlap, at least theoretically, between vascular mets from, let's say, carcinoid and hemangioma. Now, I don't think there's a problem because with the vascular mets, when there's rim enhancement, the whole thing is bright and it's homogeneous. It's not this fluffy pattern with peripheral to central fill-in. Now, filling in is not that helpful because, of course, filling in, anything can fill in if you wait long enough, whether it's hepatoma or cholangiocarcinoma. So liver lesions, again, you could say other lesions like abscesses. Patients with abscesses usually have a history of recent surgery, diverticulitis, they're running a fever. Again, not going to be typically a problem. Now, in terms of incidentalomas, the stomach, we typically don't speak about that, but we should. And the biggest challenge with the stomach revolves around technique. If the stomach is not distended, then you could overcall or undercall every case. If the stomach's distended, you can pick up incidental polyps. They can be vascular. I think you can see multiple polyps or single polyps. Now, unfortunately, unless the polyp is really aggressive with a mass and maybe some invasion, you can't call it definitely a benign polyp versus a malignancy or a polyp that has some malignant potential on it, because size is not a good criteria and the vascularity perhaps is not a good criteria. So patients would end up getting endoscopy. There are other incidental gastric masses. Some are small, they end up being glomus tumors. Some are small, and enhancing ectopic pancreas might be one consideration. And of course, we see all sorts of things from carcinoids to small intraluminal gist tumors, though I will admit that gist tumors typically are going to be larger, so that's not going to be an issue. Now, in terms of incidentalomas, what about the small bowel? We can pick up incidental intussusceptions. Intussusception, you have kind of that, here's a towel I have, but it kind of pushes in, and it has the telescoping. I'll put that towel down. And that's an intussusception. Now, intussusceptions can be due to malignant tumors or benign tumors, can be due to Crohn's disease. But in the patient's left upper quadrant, in jejunum, intussusceptions are often intermittent. They have no underlying cause, and they quickly, you don't see bowel obstruction, and they quickly resolve. So that's one of the incidental findings that was in our 12 incidental findings that people agreed on to leave alone. Now, you want to be careful with bowel incidental findings like inflammatory bowel disease, incidental enhancing lesions like gist tumors or carcinoid tumors are things we do find occasionally. Similarly, in the large bowel, incidental findings, diverticular disease, occasionally diverticulitis, occasionally appendix epiploica, but usually the patients are symptomatic with that. So we can see incidental findings there. We also see ovaries. So the ovaries in young patients tend to get bigger and smaller. The ACR appropriateness criteria became much more lenient recently into their criteria about when you follow these patients. You wait a few months before you follow the cases. They talk about the age of the patient. We also talk about how lesions look. When they look purely cystic and the patient's younger, you know it's a functional cyst, okay, or non-functioning cyst, but it's not a malignancy. Obviously, if the patient has pelvic pain, it changes things because it could be an endometrioma, but again, they usually are more solid, or if they're cystic, they have some enhancement. We talk about solid lesions, septations. We're talking about malignancy. We talk about older patients, particularly postmenopausal, that we're always worried about ovarian cancer, but not everything is ovarian cancer. So there's these size ranges that are in there. So let me just say hi to John Biacchino, who's home today. John's our tech, and yes, John, the printer is working, and Lydiana just got on. I don't know if Lydiana heard me say we hope she's doing okay, and she sent me the pictures of the fires in the area, which are not pretty. And there's Whitney saying hi with Max and Sam from Camp New York City, and waiting for the guys to go back to school on September 10th or something like that. I had the guys come visit me, and that was quite a hoot, running up and down the street. I also have a million mosquito bites. I don't know how it is where you are, but been very high humidity, a lot of dampness, but not much rain, but maybe a little bit of rain at night. But the humidity is so high, the grass takes till 10 o'clock, 10:30 to burn off. But you go out in the morning walking, and I don't know, those mosquitoes know how to go up your pants legs and up your arms and everywhere else. And I was covered, but those mosquitoes are pretty smart. Some people say, Ava Zinrag said, take B1. I don't know how many of you are expert mosquito people. You could do all that spray stuff and all that. We didn't do that. We didn't have that. And it always smells bad and stuff. And you always say, well, there can't be any mosquitoes out anyway. So, but people do say B1 takes a few days. They do give a warning, I think, that the capsules smell badly, and maybe it makes your urine smell badly. But I think if you're one of those people whose blood type is such that mosquitoes look at you as a smorgasbord, that will be a small price to pay. Okay, going back to incidentalomas. So incidentalomas, obviously the larger area we scan, the more incidentalomas. So when you look at the chest, look at the heart for a second, what's an incidentaloma? Obviously pericardial cysts can be small, they're not uncommon, they're incidental findings, they're leave-alone lesions. Same thing with bronchogenic cysts, unless the patients are symptomatic. Bronchogenic cysts, most commonly subcarinal region, right hilum, right paratracheal, we can see them, incidental finding. We can also see coronary artery calcification. It's very important to report coronary artery calcification. Obviously, at this point, you can't give a score, but if you see dense calcification and it's a little bit more than just a little fleck, well, then you know the score is well over 100. That patient needs to be worked up further. Yes, you can do a calcium score and be more precise, but just telling the patient's referring physician the calcium score is elevated, or there is coronary artery calcium, perhaps this patient is not under cardiac care and they need to be. So that's a very important incidental finding. It's one of those that can really impact the patient's life. So what I tend to do is say minimal, moderate, extensive, which means to me if it's just barely can see it, it's minimal. Moderate, there's a few little calcifications. And when it's extensive, you kind of know it. Again, you can't score, though people have worked on some work about scoring even on non-gated studies, the thicker scans. But you know, the truth is, you kind of look at it, you know yourself, doing CT for a while, you kind of know the difference between a score that's going to be 10 and 100 or 1,000. And so when you start getting the higher scores, those are the patients who really need to be worked up, if both with coronary studies, perhaps with surely calcium score, maybe coronary CTA, but surely multiple other lab studies, cholesterol and everything else, assuming that's not all been done. But that's an important incidental finding. We also talk about lung nodules. What do you do with lung nodules? These days, everyone has lung nodules if you look carefully enough. But again, most are below 4 millimeters. Most, in fact, are below 6 millimeters. And you know, there's very conservative management from the Fleischner Society on those patients. So I think we're a little bit more conservative now. Obviously, if you have a known malignancy, particularly with something like colon or it's renal, things that commonly called a lung, you want to be exceedingly careful in that regard. But most of the time we find these nodules is incidental. You want to look carefully at its density, get the thinnest sections you have, go back and look at that. Typically in the old days we said above 160. Meant the nodule is benign. I was looking around for my vitamin water as my throat is parched, but I found we got vitamin water and it's the wrong type. It's XXX, but it's not vitamin water 0. I like the red vitamin water 0. If vitamin water is listening, they can send me a couple of cases and swap out the wrong thing they send me that we paid for. So that's really the key things in incidentalomas. So other incidentalomas, you look at the bone. We often can see degenerative change. You can see osteophytes. Every once in a while, you will pick up bone lesions. Many of them are benign, but some can be malignant. You can have myeloma. Sometimes it's picked up incidentally. You can see multiple lesions. You can pick up bone mets from prostate cancer, blastic lesions. So again, that could be an incidental finding. So it does make the point that when you're doing a study, you need to look at everything. You need a systematic search. You need to look at the lungs, look at the mediastinum. Both have incidental findings. Look at the soft tissues. Look for sebaceous cysts. Look for bone lesions. Look sclerotic versus lytic. You want to look at the joint spaces. You want to look at the SI joints, things like sacroiliitis. You want to look at the organs, the liver and the spleen, the kidneys, the adrenals, the bowel, the stomach, are all things with incidental findings. We talk about the retroperitoneum, mesenteric cysts, lymphoceles, incidental neurogenic tumors are all things that you might consider and can be extremely, extremely important. So that works out fairly well. Now, I'm kind of running out of time, I think. So if anyone has any questions, this probably is a really good time to ask it. So if Max or Sam have any questions that they need answered, they can do it. They can let me know. If not, we are putting up, I just finished a series of lectures on incidentalomas, but we did an upgrade in 2019, so that's going to be our first 3 lectures. Sarah's posting in 2021. We are working on new lectures. You see them being posted every Monday. I mentioned last time that our apps, the iQuiz and the iPearls, were just updated. They're spectacular. And today we submitted the iLectures. Before we had an iLecture version for the iPad and one from the iPhone. Same content, but that's how we develop things. Now through Apple, there's a way of developing where you develop it just one time, and it works perfect for the iPhone or the iPad. And that's what this will be for the iLecture. So that's very exciting and should be a way of picking up the pace and getting things out to you. This new iLecture has 26 new lectures. Spectacular. Also, we kind of took some of the older lectures we have, and I have a hard time throwing things away, so we put them under legacy, which means you don't need to look at them if you don't want to, but they're legacy. So with that, I'm going to stop there. We hope everybody found this to be helpful. Have any questions, pearls, suggestions, or anything else? We're here. We're waiting. Give us a call. Have a great day. And now I got to figure out how to end this. Catch you later. Bye.